this machine is we take out the blood from the patient's right atrium, we send it to this machine oxygenates it, rewarms it, and it pumps back the blood back to the patient's heart or back to the patient's circulation, maintains the required amount of blood flow, maintains the cardiac output, and we sustain this patient for some days. The usual time limit that we try to achieve is around 30 to 30 days. And we can give this much of time for that pathology of lung to recover. And once the lungs recover, we can only slowly discontinue this. Primarily, this has been widely used after cardiac surgery. Patients with transplantation of great vessels with intact ventricular septum. If these patients come to us at 2 months of age, the left ventricle is already replaced. We do an arterial switch operation, but the left ventricle is not able to support the systemic circulation. What we do is, and if the patient is not able to wean off from cardiopulmonary bypass, what we do is we put the patient on ECMO. It's just another variant of cardiopulmonary bypass. The only thing is, this oxygenator can last for more number of days, but our routine cardiopulmonary bypass oxygenator can last for around 6 to 8 days. So we then put a patient on ECMO and we will stabilize him for a few days. Once the left ventricle starts, if the function gets restored, it is able to pump blood properly with the desired blood pressure, then we can safely discontinue this patient. Dr. Prakash is an intensivist from Bangalore, and he has also experience in handling this. He will tell you about the respiratory indications for it.
Hi, good afternoon or good evening, I think. Okay. So from the neonatal point of it, I think we all have faced, can you hear?
Yes.
So we all have faced great challenges in managing the meconium aspiration syndrome baby. You would have done everything, and I'm sure you have used oscillator with nitric oxide. And that is the time where you decide, my baby is still low, what to do next. The oxygenation index, which is more than 40, it can be 50, 60 or whatever. At that stage is the time when you know that before the child lands up in a multi-organ failure, if you have a center and if a patient can afford, and this is the answer for that. The reason is when you pull the data all around the world and look at how many babies survived at the time of discharge, those babies were put on ECMO. For meconium aspiration syndrome, 80% of them have survived. So it's a good percentage of babies you can say if they are put on ECMO for meconium aspiration syndrome. That's purely by just giving rest to the lungs. The second indication is congenital diaphragmatic hernia. There the results are 50-50. So again the same indications. If you are landing in a trouble, then you need to put these babies on a ECMO machine. There the pathophysiology is something different. It depends on the lung how much is mature enough. If the lungs are not well developed because of the diaphragmatic hernia, you might not achieve anything much by putting it to ECMO. The other indications are surfactant deficiency. You have given surfactant, you have done everything, but there is an infection which has set in and probably it's landed up in a kind of ARDS picture plus or minus septicemia. Then that's another indication to put the child on ECMO. And in the pediatric part of it, these are the common neonatal part of it. And the pediatric, obviously anything related to pneumonia, viral, bacteria, and the list goes on. So those are the indications to put. And when you look at the registry of all these percentages, around 60% to 70% of pneumonia cases, and these patients are identified early and transferred when they are quite intact, their survival is around 60 to 70%. So it makes a difference for that particular patient if it is affordability is not an issue. Who are the people involved in ECMO management? It's purely a cardiovascular surgeon because he is the one who can cannulate the patient, or a perfusionist who runs the machine, and the intensive care specialist who monitor the rest of the parameters, the specialized nurse who can deal with the surroundings, and obviously you need to have a good blood bank and a laboratory to assess the biological markers. So these are the few people who need to be involved. And regarding when to wean and how to wean, it's more of experience. Most of the patients, if they are just heart-related conditions, their heart should improve over the next 3 to 4 days. And if it is lung-related, probably 5 to 7 days. But centers have tried as long as 1 week, 2 weeks, 3 weeks. and Sandeep is going to discuss about the technical part of it. As you know, this can last 30 days, so we can in fact continue the patient on ECMO machine for 30 days. There are complications associated on the ECMO machine like bleeding, infection and all those things which can set in as you leave number of days on ECMO machine, but that is the challenge. You need to try to stabilize, get it out as early as possible.
See, all of us, I don't think any of us are going to handle this machine directly. Our concern is when to refer this patient to. Most of the times, there will be patient in a neonate set, conventional, exemption, nitric oxide and ECMO. In case of other pediatric, when do they go for it? How do I early anticipate? When do I say that my other system is failed? And now it's because most of us are staying maybe in the range of 100 to 200 kilometers from the center where it is available. In Bombay, you have one place it's available. In Bangalore, it may be one or two.
Yeah, that's
so
true.
most of us staying almost 300 kilometers. It's a traveling time of 6 hours at least. Is my patient will make it for that transit?
Yeah, there's a simple answer for that, sir. Actually, I'm a neonatologist too. When I land up with this problem, my understanding, my question to myself is, how long can I wait this baby to improve when I've done everything? And in our experience, in general, most of our experience, if a child is put on oscillator, you have started nitric oxide, fantastic gas, if it is just related to pulmonary hypertension. I think Rob was mentioning, as soon as you start nitric oxide within 5-10 minutes, you'll see you will blue baby become. And imagine, you know, you have started nitric oxide, it's on 20 parts, that's the maximum you can use. You are on 100%, you have a mass which is high, and you are trying to increase that, the blood pressure is dropping, and within the next 4 to 6 hours you have done everything and there is no improvement, then you need to speak to the parents, say that you have done everything, you might lose the patient, there is another option like this, we need to take a decision in the next day. That's it. If they can, well, think of those things. At the same time, you see some improvement, which can happen in most of the circumstances. This is very rare. Then properly you can bite the bullet and say, okay, let me hang on for another 6 hours and take a decision. Because if your pH is good, if there is no lactic acidosis, if there is no metabolic acidosis, if the perfusion to the other parts of the body is good, then why can't you wait rather than
The price of it?
I'll just tell you about first the machine and then I'll get on. Price of the machine? Okay. I'll tell you that consists of the pump, that's the pump. There is a heater unit which is going to monitor maintain the temperature and air oxygen render card and everything. This costs around 45 lakhs. That's the second generation machine. The first generation machine, whereas it's a little more bigger comparatively than this and has less monitoring features, this costs around 30 lakhs. But whereas we see the disposables, these disposables of the first generation machine cost around 1.5 lakhs for the patient. So this works for 30 days approval. So that CE approval is what it has. And these disposables cost around 2.5 lakhs. So that's for patients. Yes, I understand that whenever you have a patient, you have a sick patient and you are more concerned about this, at transferring the patient to other centers and all that. Even now there is a practice which is now in India is being developed. That's we can put ECMOs at the peripheral locations also. So this device is made in such a keeping all these things in mind. And we get all the parameters monitored over here. So there are special pressures which are very important for the oxygenator. So there is a pump, there is an oxygenator, there is a heat exchanger and the tubing circuit and everything. So the tubings are connected by special tubing called as cannulae into the patient. And depending on the mode of or the need of the patient, so in case if the lung is not working properly, you may, and if it is severe respiratory failure and heart is alright, you may have to go for veno-venous ECMO, where we are more concentrating on gas exchange only. So extracorporeal gas exchange happens, and then the CO2 removal and oxygenation happens into this device itself, and the blood goes back into the patient. When you have a severe cardiac failure or a combination of lung plus heart, that time we may have to have a veno-arterial ECMO. So the blood comes out of from the vein and gets into the system, oxygenates, CO2 removed, and this pump, there is a pump over here. In the first generation machine it was different, it was separate. So that is the pump. So that pump is drives and works like an artificial heart. So you can see here, that's the drive unit and that is which is integrated here. And this pump gets fixed here. So this machine, the weight of the machine is just 10 kgs and you can put in the patient on ECMO at any peripheral location, even in your hospital or even when you have a road traffic accident and lung perfusion is happening, severe lung perfusion and you're not able to manage the ventilation, you can even put the patient on ECMO on the roadside as well. The patient is drowned into water somewhere and lung again is now filled up with water, drowning. You can put the patient on ECMO, transfer him to the hospital in that situation also. Patient with severe poisoning even in the peripheral location. So even those things are happening. So those are picking up. But just to tell you, in a situation where you have all these situations, refer it to a ECMO center, where or even you can develop your own ECMO center as well in the hospital.
What is basically the gas source? What kind of gas source you need?
We have a special air oxygen blender which we need. So which is a part of this whole component equipment. So we need to have a proper control of oxygen compressed air.
You must be having those gas blenders, right, for ventilators, fixed ventilators, gas blenders.
Yeah, the same thing can be used.
So what's your experience at your center? The number of patients you must be having your own data.
See, that's what.
Can you share with us?
Yeah, sure. I was just telling over the last 5 years, I've been working over the last 5 years in Fortis, Bangalore. Fortis. So we have a pediatric cardiac department. We have done ventilations. And if you ask me about the neonatal, luckily we have not landed in that level, though we have an ECMO. That basically tells that neonatal part of these lung-related issues are very, very rare. Most of my patients were like inborn. I haven't got a very sick meconium like refer from a different hospital. Maybe those ones are the ones which are. Out of the 20 ECMOs which we have done for the neonatal as well as the pediatric, they're all post-cardiac. And we lost 3 of them. We couldn't able to get them out of the ECMO machine. And that was the initial period of us, when we started. And I think we all had to learn a lot of things, not only the technical part, but other issues were there. And out of that, the survived 17 ones, we had 3 severe neuro disabilities. One had intellectual disability, the other ones had severe hypoxemia and landed up in cerebral palsy. That was all pre-RS related. So we still have good numbers. Because that's what I was telling you, when you look at the registry, it is around 61% overall survival among the ECMO registry. So still there is a 50 to 60% chance of survival.
You keep the lungs and heart out of function for that many days, 2 weeks, 3 weeks, 4 weeks. As we understand, any body organ when it goes out of function for whatever reason, there is a problem as far as immediate as well as long-term functioning or getting it back. Reflect on the basic one. Like even if it is a badly said SARS lung is there, H1N1 lung is there, maybe a myocardium is there. How does it impact once it goes out of function? Because your machine is going to take care of it.
It's not out of function, it's partially functioning. For example, if you take heart, for example, if you take the volume load into the heart as 10 CVP, so we keep a CVP of 4. So it's like a partially working heart and partially working lung with lung protective ventilation.
Instead of putting the actual load, you just allow the heart to just relax. And the lung also is not like ventilating that. But true, 30 days or whatever it says, 30 days is fine. But in Indian scenario or even in a Western scenario, I don't think so any patient will be kept for more than a week, honestly, because the center where I worked for a very bad pneumonia, I was hospital for sick children in Toronto. The maximum was 2 weeks there, and we had to decide that we have to take him off.
Was it because of the financial constraint?
It was not, because we knew that the lung is never going to improve, and that was determined based on clinical evidence as well as the lung biopsy. It was fibrotic, it was necrotic, so they had to prove it, otherwise they will be caught in the court. So when you take out a patient from ECMO, they have to justify why they are taking out in those countries. But here, I'm sure if the heart is improving, Sandeep will agree, within 3 days it will improve, 3 to 4 days maximum. If it is lungs, probably you can try for 1 week. If it doesn't improve by then chances of survival is very unlikely.
We have this facility with us, we haven't used it anytime. हमारे पास डिस्पोजेबल तो हमको मंगाना पड़ता है, तो उसका जो मेन यूनिट है सेंट्रीफ्यूगल पंप, बेसिकली फंडामेंटल ये है कि पंप रोटेट्स
Including everything. This is the main cause.
Blood is not dialyzed. Blood is not dialyzed.
we can if we want we can do it.
Then it is oxygenated or it is dialyzed
It is
also.
oxygenated, but if you want, say if we have a patient who has gone into a pre-renal failure because of his hypotension, because of his cardiac dysfunction, we put a patient on ECMO and is still not getting his urine out. What we can do is we can add a hemoconcentrator to it. The hemoconcentrator will filter out urine, and as it starts filtering out urine, slowly as the kidney recovers, and the kidney starts filtering out urine, we can discontinue the use. So that additional facility is always allowable in that.
What people face in that
We have perfusionists.
Two main persons are
He
important.
used to be our perfusionist in Narayan Hridayalaya, Bangalore. And then when he finally left,
He has joined the company itself.
we have put in lot many of ECMOs. More or less what ECMOs we used to put where one after cardiac surgery the patient is not coming off bypass, we used to put a patient on ECMO. If we used to have patients whose lungs become bad after cardiac surgery, the heart is a little better. But now we know that he is going to require a lot of ventilatory support and probably not maintaining his circulation. Sometimes it used to happen that due to some unknown reason, these patients used to go into sudden cardiac arrest in an ICU. Then if we start our regular cardiac massage and resuscitative therapy, and in 5 to 10 minutes we are not able to resuscitate and bring back the cardiac function, then immediately what we used to do is we open the chest, put up the arterial cannula, put a aortic cannula, set this ECMO machine within 5 minutes, and we use it just to let the ECMO run. The heart gets time to recover. Probably initially, as soon as we used to connect the patient on ECMO, the heart just goes into a standstill. Immediately it knows that its work has been taken care of, so it will just rest. Then after 1 hour, the heartbeats will start. Say at 10 beats per minute, 20 beats per minute, 30 beats per minute. And then it used to beat properly. Within a day or two, now we realize that the cardiac function is improved. Then what we do is we reduce these flows. As we reduce these flows, we then see whether we give a preload to the heart. If the heart is able to eject it, then we give some more preload to it. Then if the heart is again able to reject that preload, then we increase the preload to the heart, we have to reduce the flows with this machine. Thereby test the heart. And once we know that yes, the heart has recovered, it is able to maintain the blood pressure on its own, or at least with the help of some inotropes. Then this is what we just discussed.
how coronary artery is perfused during standstill?
That is because this blood is going into the aorta. It is maintaining the aortic perfusion pressure. That is the key.
Backward pressure will
Pardon?
aorta will cannulate after the coronary.
Wherever we cannulate, it is going to go blood to everywhere.
Yeah, so backwards also it will come.
It is always Pascal's law. It will fill up whichever outlet that it gets.
You said the heart was in standstill for 1 hour and then starts beating of its own, or you are doing something?
No, we don't do anything. The heart just rests. It has lost its calcium. It has lost its metabolites. This
Pardon?
No, we are not giving
This is post-cardiac arrest.
This is post-cardiac arrest. The heart has lost its calcium, so it waits. It gets nutrition. As it gets nutrition, it gets its calcium, it gets its ATP, and then again it starts functioning. Might take 1 hour,
Can take
2 hours, but still
When
we
you
have seen
decide that it's not going to make it.
if by around 2-3 days we are not able to see a good perfusion pressure, we try to give a preload.
Suppose the heart doesn't start beating up.
It doesn't happen like that. The heart starts beating once we put on ECMO. Say after 1 hour or 2 hours the heart starts beating. But the crux is whether this heart will maintain the perfusion after once we start giving it blood. It might happen that we reduce the flows by 50%. We give 50% load to the heart and the heart works. But then as we reduce the flows further, we give 75% work to the heart and it doesn't do it. And if this continues for at least 3-4 days, then probably we realize that this is
So this is, what you see here is a ventilator. Okay? This is developed by me and my close friend Raymond Beatty. So this has a gas flow, as you can see here. Okay? This has an endotherapy tube and the patient is connected here. Okay? This is inflating and deflating, as you can see at this point. Now, from here on, I will take you to tissues. These are tissues which are consuming oxygen at about 6 ml per kilo per minute. So you have the deoxygenated blood coming here and entering the right atrium. From here it goes to right ventricle, from the artery, and from there on to the lungs. If all is going well at this end, then this blood will get oxygenated, will become red, will come to the left atrium, into the left ventricle, into the aorta, and back to the chest. Okay. Now, lung is not a homogeneous structure which will have alveoli which will be behaving exactly like this. And there will be some tricky issues which could be making it difficult for you to understand what are the tissues and the hypoxia. For example, if all is well at this point, this is alveolo-capillary membrane. The gradient is about 10 millimeters of mercury. You can stop at any moment if you don't realize, understand this, okay? So now let's imagine that at this point the blood is properly oxygenated. So even a patient at this point, you have analyzed his PaO2. It is normal 100. SaO2 is normal 100. Does that guarantee that tissues are getting adequate oxygen? No. Next point.
Acid.
They will go by what atoms?
Periphery vasodilation.
Yeah, that's right. This depends on perfusion also. Right? And that's why shown heart in the center. So even if your blood is properly oxygenated, it may not be properly perfused. Let's say perfusion is not. It doesn't make a difference in delivery bubbles. Wouldn't care even though you work much.
Oxygen delivery.
No, we are not at this point still. We are here. Hemoglobin, extremely important. Okay, so now let's say your hemoglobin is normal. So at this point, your hemoglobin is normal. Your blood pressure is normal. Your PaO2 is normal. Your SaO2 is normal. So what can make tissues, or is it a guarantee that tissues are now getting adequate oxygen? What's the problem? Okay, no abnormal hemoglobin. What else?
Acidosis.
Acidosis will benefit the tissues by shifting the curve to right. So it doesn't make much difference.
Hypothermia. Hypothermia.
Yeah?
How is
But we have said ultimately they will affect the perfusion. So perfusion is normal.
Hypothermia.
Hypothermia under the perfusion is normal. What else can perfusion hypoxia, which is common in case in everyone.
Sepsis. Sepsis. Sepsis.
But how?
Septic
What
shock.
do toxins do?
Capillary
They
leak.
would do?
Capillary leak.
They would do like what the government of India does. Corruption. And that corruption is they will shunt from here to here. They shunt from here to here. And this is a global shunt. These are glomi, which are three capillary shunts occurring from here to this limb. Now if you have a shunt like this which occurs in two types of septic shock, there is no way you will know there is tissue hypoxia. Even if you measure saturation at this point, which is now a recommendation, even a SpO2 measurement would be fallaciously high in these situations. So these glow merchants, even the government tries to do what is called a DCT, direct cash transfer, and they have intentions to transfer to the farmers, these funds, you see that nothing reaches the tissues. Okay. Anyway, now we have done this. Now we have seen the heterogeneity of circulation. Let's see the alveoli. The alveoli are also not homogeneous. Like this alveolus is behaving alright. It is getting inflated, deflated, blood is properly perfused. This alveolus, if I stop the ventilation here, then what happens is that this is what happens. You understand this? The blood is not getting oxygenated and it is getting mixed with the arterialized blood and your patient will remain hypoxemic. Right? So this depicts a ventilation perfusion abnormality in an alveolus which is not getting ventilated. This alveolus is getting ventilated but is not perfusing. So it is adding to the dead space of this system. And normal dead space of 10 to 15%, the critical dead space level, which is 20%. Beyond that, the work of breathing will be detrimental. It may not make a difference on a patient with mechanical ventilation, but it would make another difference that we will discuss in time. This ventilator also shows you all the available things that you hear on the conventional ventilation. Like we have tried to develop a different sensor, like we have flow sensors which are very costly. What we have done is we put a fan here. This fan moves depending on the speed with which the air comes and goes in, and that speed is taken by a sensor and put on a Microsoft Access file at about 1 milliseconds rate, and we develop a graph, which is a cheaper way of developing the graph coming from this. And we have a solenoid ball. You must have heard of these balls in most latest ventilators. This solenoid ball is electronically operated. Okay? And now I have given an I ratio of 1:4. Okay? 1:4 ratio. Yeah. That's an I ratio I've given here. I can change that ratio or I can change the rate of this flow. As you can see here, as it goes from here, there is a bubbling of this through a level of water column. It is about 4 or 5 centimeters. If you increase it more, this will be more exhalation pressure. If you raise that level, it will be less of CPAP. So this is these elements which you will see here. And the graph that develops can be shown in this. This is a typical graph of a pressure control ventilation, the pressure level. The flow is different. Flow on a pressure ventilation goes up like this, decelerates till the time the inspiration ends, then goes below the level and then comes back to the vessel level. This kind of graph I will show you drawing on this. In fact, how that you can know the way the fan moves, we are using nitrogen here for some technical reasons, and nitrogen is not easily available. There's some, we're just conserving on the gas. So this, the way it moves, can tell me, it's easy to have a barometric pressure. We have these small little meters on the usual old ventilators. They can be used for measuring pressures. It's not easy to have a flow. This fan speed can give me mentally what level of flow that I can even measure on my laptop by a sensor that is. So these are certain things which are developed on this. Have you understood this, Shan? Any questions? The station also thinks of See, we are on an advanced ventilation workshop. Some complex things will be discussed. They can be difficult to understand. But let's see, the patients who have, when we talk of airway resistance or airway compliance, we have discussed the heterogeneity of alveoli. The same is true even of airways. For example, there could be an airway. So it's easy to understand this on a volume ventilation. When you have a volume ventilation, the graph that you get is something like this. This graph tells you this is an equilibrium pressure, this is inspiration. Now what happens is when the gas flows in, you reach the PIP, but there is an equilibrium constant time which takes some time to equilibrate, and this is called an inspiratory hold on a volume ventilation. Now when you hold the inspiration during inspiration, what happens? The gases that you deliver to the proximal airway would reach the alveoli. This gap is the compliance of the system, this is the resistance of the system. Looks good on paper, but in reality what happens is that you have an airway which is coming like this and an alveolus which is like this. When you put a gas, this airway is a low compliant airway. Means it is hard in a simple word. Since low compliant, what it does is it takes time for it to distend. So distance like this is hard to distend. By the time it got fully distended, your inspiration is over. And nothing has flown into this alveolus. Okay, nothing has flown into this alveolus. Since nothing has flown here, when this tends to come to normal, this distance here. So you have an alveolus which is getting distended, when in fact on a ventilatory phase you are on inspiration. Okay, so here now at that moment this alveolus is getting distended during exhalation. Hemant? Hemant? So this is getting distended. This is Mr. Hemant Vidhi. He is a close friend of mine. He helped me in designing this bottle. In fact, I drove him mad for the last few months. Literally to do it. And anyway, it worked out well. So like, you know, when this happens, it was not, you know, you are in a paradoxical phase. You are putting in a gas, okay? Some alveoli are getting distended, and the other alveoli are getting distended when you are exhaling. This is a dynamic variable compliance or dynamic heterogeneous compliance. In this situation, there is not much that you can do. What you could do here is to split the airways. So you could use a high frequency ventilation to split the airway, and this alveolus then be applied by just oscillating in that situation. So certain things which are possible. So you have heterogeneities of alveoli, you have heterogeneities of the vascular system, and you have heterogeneity amongst the own areas of airway and alveolus. So there are certain complexities which could happen. At the moment there may not be an easy solution to it. There is no evidence at the moment to suggest that a high frequency ventilation does well also, but then it does split the airway naturally. Any questions on this? Rob, anything you would like to add on this?
Sir, this is a mark of hearing.
Yeah, Rob, I'd like to meet my friend Hemant. He is the electronics chap I drove mad in making. He is Dr.
Wonderful.
John.
You helped with this flight simulator. So I gotta go tend to that for a moment. But,
Sure.
so we'll deal with mine here in just a few minutes. I really like that. Are you sure I can't take it with me?
Any questions on this? Yeah?
The functionality of the alveoli is lost to me.
No, we are not splitting the alveoli. We are splitting the airway.
So you split the airway.
Yeah.
The function is to prevent over distension of the alveoli.
Right. No, very good. Now what happens is the alveoli get over distended when the airway expands and now it wants to come back to normal. The time is less. So you are now at an inspiratory phase. See, normally when we ventilate, we have a longer exhalation phase and less. That's a very bright question you asked. Now during inspiration, this time is short and you want to come back to normal position. So the force which you generate is much more and you in fact do this now. So that is.
So basically by splitting it you maintain its functionality as well.
Yeah. Yeah, very right. This kind of things you see in Meconium-Massacre syndromes and ecopyramidal defect. No questions? Now, in fact, just to simulate this further, our next model, I'll show you the working heart model tomorrow, which will be at the center of this model, so simulate the circulation. But the next thing that should accompany this model is you may ask me, you don't paralyze every person. So this model doesn't represent that, but what we're developing a lung over this lung. So that lung will ultimately have a vacuum created like an intrapleural pressure. And when the vacuum gets created, this lung will expand. So it will simulate a normal breathing lung. And we're going to use the syringe with a driving pump to do this. So it will simulate that kind of simulator which you see there, which will have a simulation that happens with a normally breathing lung. At the moment that we are not able to do it. But the important thing is the cost. This was made in 20,000 rupees. That will be costing 6 crores. And has these components which are comprehensive, so you get a feeling that you have ventilation perfusion relationship, which is a very important part of achieving a proper oxygen. Any questions? Yeah, see the fan, speed simulates the flow. More is the fan is slightly different in design. What we've done is, so the blades of the fan, there's some are like this. When the air strikes, okay, the fan moves at the rate at which it moves. Yeah. All
ones that you would manage here in India. And what I would like for you is we'll propose these clinical scenarios, and then I'll have questions to ask you. So each one of you will be able to raise your hand. Usually we have a response system that we can use, but I don't have that automated response system with me because I brought the lung model. I couldn't bring anything else. So we'll just raise our hands, and maybe you can help explain why you chose the answer you did. If you don't want to answer the question, that's fine. We can go into detail about why we think the answer should. There's no right answer, by the way. You know, there's no perfectly right answer. There's just multiple answers, and I hope that these will stimulate discussion between all of you. So we'll start with the first patient. We won't waste any time at all. This is going to be a 28-week premature girl, 800 grams, transferred from the neonatal intensive care unit. The mom had premature rupture of the membranes. The baby was given surfactant once in the delivery room. So this is a baby that was supported within 5 minutes, had severe respiratory compromise with hypoxia, increased work of breathing, was given the surfactant in the delivery room, and then was immediately extubated after being ventilated for only about 45 minutes. So this baby is now in the NICU. The heart rate's 180. The respiratory rate is 42. The SpO2 is 89, and this baby's receiving blow-by oxygen at about 50% FiO2. We have diminished breath sounds with bilateral crackles, intercostal and substernal retractions, grunting, and nasal flaring. So this is what the baby looks like. So notice the baby's working very hard to try to move gas into and out of the lung. The baby, if you get close enough, you can hear that the baby's grunting. Baby has nasal flaring, so a tremendous amount of work of breathing. So
one pearl about looking at somebody breathing. If the patient what was the time of premature rupture membrane?
Yeah, so the baby was in for over 24 hours after premature rupture of the membrane.
If you are looking at your patient and you're watching the patient and this is making you uncomfortable, the patient needs to be intubated. You don't need to have a blood gas. If you breathe like the patient yourself and you are uncomfortable, the patient needs to be intubated.
Now we're gonna have an interesting discussion about whether or not that patient needs to be intubated, right? Because he was just intubated for surfactant. Is there something else that we could do for this child as an alternative to intubation? We've talked about this a little bit. This is what the x-ray looks like. All right, we already gave surfactant, but this is what the x-ray looks like. Baby has respiratory distress syndrome and is breathing very hard. So what type of x-ray?
Does anybody know, does this child meet criteria for ARDS? The saturation was 89%. What PO2 is that? It's about 60. The baby was receiving 50% oxygen, so the FiO2 is 0.5. So the PO2 FiO2 ratio is 120. This patient has severe RDS or ARDS at this point.
Excellent. So based on the fact that the baby's premature, has high work of breathing, has an oxygen requirement, and has an x-ray that looks like that, we know that this baby definitely requires our assistance. Okay, so I'll bring you to the first question. What would you do in this situation? So I want to start hearing from all of you. A, I would administer O2 by nasal cannula at 12 liters a minute. I would place the baby on CPAP at 6 centimeters of water pressure and FiO2 is 60. I would increase the FiO2 blow-by to get about 0.9. I would intubate the baby right away, or you would hope that your replacement arrives early. Okay. How many of you say B? Okay. How many of you say C? How many of you would intubate this baby? Okay, so it's interesting. About half of the room said that they would place him on CPAP, and about half of the room said they would intubate him. That is exactly what's going on in the United States right now. Half of the people would say, let's intubate him, give him surfactant, put him on a ventilator. And the other half would say, no way, man. We know that that's going to create lung injury. So why would we do that in the first place? Let's manage them on CPAP. If they don't look good on CPAP, then we can always do that. All right, I tend to hang with you guys, the less invasive crowd. I would try CPAP on that baby no matter how bad he looks. In fact, some of the guidelines that are being used in the delivery room nowadays suggest that if the patient has any respiratory effort at all, okay, whether it's weak or ineffective, as long as they're breathing, you should always try them on CPAP. Because you never know. You could eliminate the need for intubation in this particular situation. Most likely not, though. That baby was working pretty hard. But either way, you're right. Okay, you're both right. The smaller the gestational age, the greater the need for intubation, because we need to get the surfactant in there as quick as possible. So, we were paged immediately, and the patient was having frequent apneas and desaturations and Brady's. Those are really the endpoint, I think. A lot of neonatologists consider the true endpoint in this patient population is going to be whether or not they're desaturating, they're having bradycardias, and if they're becoming apneic. Clearly, we can't support infants that are on nasal CPAP with apnea, even though nasal CPAP reduces the incidence and the severity of these apneic episodes. We still we need them to be breathing. So this patient's breathing at a respiratory rate of 80. Saturations are 85. We're now up to CPAP of 8 centimeters of water pressure, an FiO2 of 80. How many of you would actually go up to CPAP of 8? What's the highest CPAP you like to go to? 7? Okay, so 60 is your endpoint on 8. On 8, yeah, I would agree. That's what a lot of people are doing. But this is a very aggressive institution. And the breath sounds are absent in the bases, diminished throughout. There's frequent apneas responding to stimulation. They've had to actually manually resuscitate a couple of times to get the baby breathing again. So if you're having frequent apnea, that's your indication right there. If you don't have blood gases and you know the patient's working hard, but they're having apnea, the reason why they're probably having apnea is because they have airway obstruction or they have some central component. Maybe they have hypoxemia, they have hypercarbia that's promoting this type of behavior. So you get a capillary blood gas, and most of the babies in the intensive care unit nowadays are being managed without an arterial line. A lot of the babies in our unit are being managed without an umbilical line because that's been removed, and now we trend CPGs, capillary blood gases, and look at saturations. So that's all we have right now.
So Rob, what is the PO2?
So we don't really know what the PO2 is. This is going to be your capillary PO2.
Capillary PO2.
And so this does not necessarily reflect what your PaO2 is, right? So this will generally read 20 to 30 lower than your arterial PaO2.
But it does mean something.
Yes.
This child has reduced cardiac output in addition to his lung disease now, and is extracting a greater amount of systemic oxygen. So I would say this child is in dire straits.
Absolutely. And because this patient has anaerobic metabolism, we're probably producing a lot of lactic acid, and that's one of the major, aside from being premature and having premature kidneys, we may be contributing to that metabolic acidosis with some lactic acid building in the bloodstream. Okay, so this baby is definitely in dire straits. So what would we do? Would we continue CPAP and observe closely? Would we intubate and initiate mechanical ventilation? Would we give an albuterol nebulizer? Or would we give caffeine and see how they do? B. Everyone agrees, B, right? Okay, good. We're going to intubate that baby. All right. So the baby's been intubated, and the endotracheal tube is secured at 8.5 at the gums. All right. A chest x-ray is obtained. We're currently on SIMV with pressure control at a respiratory rate of 60, a PIP of 25, PEEP of 6, I time of 0.3, FiO2 is 80, and the SATs are 75%. The breath sounds are absent on the left side with good aeration on the right with fine crackles. Here's your first x-ray. Huh? Excellent. So should we place a right-sided chest tube? Should we reposition the ET tube? Should we repeat the chest x-ray, perform CPT to the left lung and right upper lobe, or do bronchoscopy? How many of you say A? None of you say A? Really? Well, that's a good thing, because you're right. Reposition the endotracheal tube, right? That endotracheal tube is buried. Typically, you want that endotracheal tube just within the thoracic inlet, somewhere between the clavicles and also the carinal air shadow. So usually we would like that around T3, T4, the endotracheal tube. Now, this baby's chin is down, and when your chin's down, your tube's down, right? But we know that that tube has advanced into the right main stem because our right upper lobe is collapsed and our left side is completely collapsed. So if this endotracheal tube is at 8.5 centimeters at the lip, what should we be placing that at? Ah, good. Because this baby is almost 1 kilo. You guys are too good, right? So the rule of 6. We always remember the rule of 6. If they're 2 kilos, secure it at 8. If they're 3 kilos, secure it at 9. Good. So we pull the endotracheal tube back and everything seems to look good. Now that we've stabilized our patient, have we? So if we observe the chest x-ray here, has anything gotten better for this baby? Well, yeah, the baby's now intubated. But let's look at the pressure volume loop. Jerry, would you like to comment on that pressure volume loop? There you go.
So what you see here, or what you don't see here, is inspiration is the red line on the bottom. And you can see that the pressure has to increase to about 26 or 28 before there is any change in volume. So volume is on the y-axis and pressure is on the x-axis. So this is a pressure volume loop. And before any volume is introduced into the lung by this pressure control of ventilation, it takes at least 26 centimeters of pressure to deliver that volume.
Great. And so in this particular patient, we're using pressure control ventilation, not getting much, using a high pressure, not getting much volume. We know that this patient has low lung compliance. And if we measure the lung compliance dynamically on the mechanical ventilator, it reads 0.3 mLs per centimeter of water pressure. Typically, your compliance should be 1 ml per centimeter water pressure per kilogram. So in a newborn baby with RDS, you should be looking at a compliance of about 1, and it's about half of that now. So this baby has some serious issues. So what will we do next? Should we continue ventilation and observe closely, perform an alveolar recruitment maneuver and hold it in there, pressure for 30 seconds, give a second dose of surfactant, increase the inspiratory time to 1, or reduce the set respiratory rate? How many of you say C? Okay. What do you think? Those of you that didn't raise your hand, what do you think the answer should be? What's that? Observe ventilation, or just look at ventilation? Okay. Okay. Some of you may take a different approach, but in this particular situation, we're going to give a second dose of albuterol, of surfactant. And you can do this within a 24-hour time span. If you need to give a second dose, usually we will give the dose 6 hours after the first dose. Clearly, this baby was having some issues, and based on some meta-analyses from 3 randomized control trials, a second dose is preferable compared to a single dose. Multiple doses of animal-derived surfactant has been shown to reduce the incidence of pneumothorax, and there's a trend towards reduced mortality. But multiple doses of synthetic surfactant appear to be a little more effective, and they may reduce the incidence of NEC, and of course will reduce the incidence of mortality. So don't be afraid to give your patient a second dose as needed. Okay, so we gave that second dose of surfactant, and this is what the baby's x-ray looks like, and this is what the baby's pressure volume loop looks like at this point. The FiO2 is 50%, so we're able to wean our oxygen down. The respiratory rate is 60. The PIP is still 26, okay, and the PEEP is set at 6. Your blood gas is 749, 25 for the PaCO2, 65 for the PO2, and we have 18 for bicarb. Tell me, based on this flow volume loop, what your exhale tidal volume is in mLs per kilo, if you don't mind. Okay, one of you said 10. Okay. Any other, 4 to 6? That's what it should be, right? But right now, it's not either. Okay? Did someone say 20? No. Okay, so look at your pressure volume loop. And on this axis right here is volume. On this axis right here is pressure. We require a very little bit of amount of pressure to be able to move volume into the lung now. And there's some mild overdistension at this point. This is an actual patient with RDS. I'm not going to say it's my patient because I wouldn't have let the volumes get this big, but let's just say that you didn't set that tidal volume alarm appropriately. Follow this volume over here. 18 is our tidal volume. If this kid weighs 0.8, it's almost 1 kilo. What's my tidal volume dosage? 18 mLs per kilo. Is that acceptable for babies? Okay, what will happen to this baby if we don't wean the pressure? Jerry's pointing out something critical to you, this hyper expansion of the lung. Okay, so we're going to run into problems with air leak. This baby's going to develop PIE. This is not acceptable. You need to monitor tidal volumes at the airway, okay? Or you need to calculate the amount of volume that's being delivered to the baby based on a simple equation. PIP minus PEEP times the tubing compliance factor divided by your exhaled tidal volume. Okay, that's one way to go about it. If you don't have the ability to use a proximal flow sensor in these patients and monitor graphics and tidal volume, take your PIP minus your PEEP times your tubing compliance factor, which is usually 1, divided by your exhaled tidal volume. Exhaled tidal volume back at the ventilator. I can point that out to you. We're going to move through here. I'll tell you the equation a little bit later.
So the big thing that's happened here is, if you remember those two pressure volume loops, the first one was almost square with no change in volume, with increase in pressure to 28. So essentially the slope of that line was 0 for most of the pressure, as compared to this after the second dose of surfactant. The slope of this line has increased dramatically, and the opening, the inspiratory inflection point has been reduced from 28 down to about 10 or something like that. So the pulmonary surfactants has drastically improved the compliance of the lung, which means for the same pressure, you're going to get a lot more tidal volume, and this places the baby at risk for volume trauma, hence the need for measuring the tidal volumes.
So by hyperventilating this patient, you also put them at risk for something else. Okay? Does anyone want to tell me what this baby's, Vasoconstriction in the brain. What might that cause in the brain? Ischemic changes, all right? We can cause what's called periventricular leukomalacia. So when you have a low CO2, you cause cerebral vasoconstriction. You reduce the amount of blood flow that's going to the brain, and that can actually reduce the oxygen carrying capacity to the tissue, and that will result in brain death and cerebral palsy. So it's important that you not only monitor tidal volume, but also you try to measure gas exchange somehow, whether it's an end-tidal CO2 or capillary blood gas. But by now, we look at chest rise, and if your chest rise is excessive and you don't have the ability to calculate or monitor tidal volume on your ventilator, you need to turn that pressure down until you get minimal chest rise. Just roll with that. Okay, so what would be your suggestion now? I mentioned that the tidal volumes are approaching 20 mLs per kilo. Normally, we would try to keep those tidal volumes around 5 or 6 mLs per kilo. So are we going to increase our PEEP, wean our FiO2, continue pressure control ventilation, and decrease the PIP by 2? Or are we going to initiate volume targeted ventilation? C, okay. I'm going to agree with you there for now, but we need to start changing the way that we're thinking. There's questions. Please. Oh, you said D. D. Oh, I like that. Volume targeted ventilation. Anyone else agree with the gentleman in the front here? Volume targeted ventilation. Anyone else? I'm putting my hand up too. We might change some things today. That's my goal. Okay, we want to try to introduce to you some new ventilator approaches that can result in less injury to the lung. Volume targeted mechanical ventilation is one of those that now we've learned from the adults. Ed Karakin mentioned earlier that we extrapolate oftentimes from the adult studies. Well, we've done that, and we found that based on ARDSNet approach, it's better to target tidal volume than it is to target pressure, because it's really the volume that's going to cause lung injury in these patients. So I'd like to share with you some new data that's been published from the Cochrane Review. Actually, there's been a more recent version of this, 2011, and this is an old, outdated slide. In this Cochrane meta-analysis, there's now 6 randomized control trials that have randomized to over 600 patients, and they've compared outcomes in these premature babies that were supported by either volume-targeted ventilation or pressure-targeted ventilation. Pressure is what I've used for years. Recently, I've gone over to using volume-targeted ventilation. One of the major limitations in the past is that we haven't been able to target those itty-bitty tidal volumes. nor have we had the ability to actually monitor those volumes. So these volume-targeted modes of ventilation are like pressure control, except the pressure is going to wean automatically for you based on if the tidal volume is larger that's being measured at the airway. So if you set that tidal volume for 5 mLs, and this is a 1 kilo kid, you're going to get less variability in that tidal volume than you would with pressure control. And they found that based on these studies, there's been a reduction in the length of ventilation, the incidence of pneumothorax, the incidence of severe grade 3 and 4 bleeds, but also a reduction in periventricular leukomalacia because the pressure is able to wean down. You're less likely to expose those larger volumes to the babies, and you're less likely to hyperventilate that patient. But also, this is an old slide, as I mentioned, there has been a reduction in the incidence of BPD, combined outcome of BPD and mortality in the group that's supported by volume guarantee or volume-targeted modes of ventilation. There are several different types of volume-targeted mechanical ventilation. I don't have time to really get into those today, but if you have PRVC or you have volume guarantee, you have every one of these ventilators in the room right here are able to do some form of volume-targeted ventilation. I would suggest that you learn how to use that. No, gone are the days where you have to get multiple blood gases and sit there and reduce the pressure. This will keep the volume constant and vary the pressure for you. All right, so what tidal volume should we use? 3 mLs per kilo, 5 mLs per kilo, 9 mLs per kilo, 12, 15? Is lower better than higher? How many of you guys going to say A? Lower. Okay, you said 3 mLs per kilo. Who says 5? Okay. What about 9? Anyone for 9? Okay. Not in a fresh newborn. Maybe in a kid with BPD that has distended airways, and that's the only thing that you can use to get a chest rise. Then yes, you would use 9. But this is a fresh newborn. This is a fresh preemie. So 5 mLs per kilo, I'm going to agree with you there. And the reason why I'm going to agree with you is because there is a great group out of Italy that has been, they've evaluated lung injury by simply suctioning the infants with a clean, sterile suction catheter, and they've looked at pro-inflammatory markers in the lung, and they've compared between tidal volume of 5 ml per kilo and tidal volume of 3 mLs per kilo. And what they found is that after 7 days or so, sorry about this slide, the interleukin 8 levels were much greater in those infants that were supported by 3 mLs per kilo. So what does that mean? It means that if you use too small a tidal volume, you create lung injury because the lungs don't fully open. All right? But if you use too large a tidal volume, you over-distend the lungs. But in this particular study, the inflammation in the lung was much lower in the group that was provided with a larger tidal volume, 5 mLs per kilo. I would start just about every baby. Don't confuse yourself with 4 or 6. Most of the babies that we take care of nowadays, I would just start with 5 mLs per kilo and avoid 4, especially since you're using a proximal flow sensor and you want to try to purge the system of dead space. Okay, so we're not going to ever conduct a study like the one that Dr. Foley mentioned this morning, the ARDSNet study. We would never subject babies to 12 mLs per kilo or 4 mLs per kilo. We found that most of the babies do quite well if they require invasive mechanical ventilation to support them with somewhere around 5 mLs per kilo. Excellent. 3 days later, the RN comes in and she says that the baby's really tachypnic, and the baby developed this tachypnia after she turned him. You suction the patient, but there's no sputum. There's no increased work of breathing, but the respiratory rate is super high. Okay? This is what's going on with your baby. These are your airway graphics. So the respiratory rate went up immediately, but there's no increase of work of breathing. Okay? We'll let that burn into your mind just a little bit, this graphic. Does anything come to mind looking at this? Leak. Okay, good, good. So we look over here, there's a 52% leak. All right? Every one of the breaths are regular. All right? There's no variability. The baby's not even breathing. So if you look at this type of graphic and you see this in a baby who was previously breathing at about 40, now the nurse turned the baby and the leak went from 20 up to 50, something's going on. And yes, most likely it's a leak. So how would you do this? Would you return the patient to the prior position? Would you increase the flow trigger level or reduce the sensitivity? Would you reduce the flow trigger level and increase the sensitivity? Or would you reduce the set respiratory rate? A or B? Or C? How many of you say A? How many of you say B? Make it less sensitive? Or C, do we make it more sensitive? Okay, C. If you make it more sensitive, I don't think that's going to help your baby too much. Okay, yes, B. So you're going to increase your flow trigger level. We're going to let the baby lay on the side because he's starting to get some, you know, he's starting to get a little bit of a toaster head, so we'll let him lay on the other side for a little while. So just by simply going up on the flow trigger from 0.5 to 0.7, we've now eliminated this spontaneous triggering of the ventilator rate, and it's likely that we got his CO2 back down into a normal range, because if you have a baby that's continuously autocycling, you're driving that carbon dioxide level down. And what do we create? Periventricular leukomalacia, just by turning our patient. We tried to help the patient, but we could put them at risk for developing this cystic brain lesion. Let's move along and talk about this patient now. You guys did a wonderful job, by the way. Thank you. Now, the same baby, well, I'll say that this was the twin cousin. No. This baby developed severe BPD. This is going to get a little more difficult. That first one was a freebie. Okay, now I'm going to really need you to be interactive with this patient. These BPD patients are some of the most complex babies, the most technically challenging babies to manage on a mechanical ventilator. This was a former 24-week preemie, has severe BPD, has tracheomalacia, was admitted to the PICU with tracheitis, increased work of breathing, and fever. Now the baby's vent dependent, has a tracheostomy tube, and you can notice that there's some cystic changes in the lung. There's some areas of hyperinflation and underinflation here, and the diaphragms are relatively flat. SIMV over pressure, with pressure control ventilation. Our pressure control level is 28. The PEEP's 5, pressure support's 8, and the FiO2 is 60. So we are monitoring tidal volumes with this baby, and those tidal volumes are 10 mLs per kilo. Is that okay for a kid with BPD? Is 10 mLs per kilo? This should be relatively new to you, but yes. In these particular patients, we didn't have the ability to ever measure tidal volume before. And we would use as much pressure as is necessary to get a chest rise, right? But now that we're measuring volumes, people are coming along and they're weaning the pressure way down because they want to still keep them at 4 to 6 mLs per kilo. But keep in mind that when you ventilate a relatively stiff alveolus through a compliant airway, in time, that airway becomes floppy. And in order to ventilate that lung, you have to use these higher pressures and these larger volumes. It's absolutely essential in order to maintain gas exchange. This baby has been getting Q4 albuterol treatments. These bronchopulmonary dysplasia kids absolutely respond to inhaled bronchodilators. However, shortly after giving the bronchodilator, the kid is having a hypoxic spell. How many BPD kids do you have that just have increased respiratory distress, they turn blue, and you need to turn their FiO2 up and sometimes sedate them because they don't look good on the ventilator? Okay? It happens quite frequently. But we don't always know exactly what's going on with those patients because we're not suctioning a lot of secretions. However, we just sedate them and paralyze them, and that's not necessarily a good thing. We need to look a little bit closer. So this baby has coarse expiratory, prolonged expiratory wheezes throughout, has, of course, increased work of breathing, active exhalation. So when you have an active exhalation, your pleural pressures are quite high. All right? So this kid will work really hard and then finally go apneic. All right, just have this periodic episode and decompensate. So if we're able to, pardon me for this little thing up here, but I want you to pay attention to this flow volume loop. This is inhalation, this is exhalation. And what we're going to do, okay, I want you to look closely at this. Something's going on. Is this a normal flow volume loop? No? Someone want to try to guess what's going on here? This is a very important graphic for your BPD kids. Normally, this is supposed to gas in, the flow is supposed to come out. But once we reach the peak expiratory flow, something's happening. Flow is going to zero. It's not supposed to happen. Then it goes back out and goes to zero. What do we think's going on here? Huh? The airway's collapsing. Expiratory collapse. Why would that happen to these babies? Excuse me? Speak up. I didn't quite hear you. Sorry, but I got something going in the back here. Okay, so the question for you is, is this most consistent with inappropriate set inspiratory time? Obstruction related to tracheomalacia. Severe distal airway obstruction, large airway leak with autocycling. How many of you are going to say A? Okay, we got one. How many of you are going to say B? Okay. How many of you are going to say C? Okay. How many of you are going to say D? Okay. Wow, this is great. There's a good variation here. So what would be your management for this particular patient? Would you decrease the inspiratory time? Would you administer a stat bronchodilator treatment? Would you increase PEEP? Would you increase the trigger sensitivity? Or would you phone a friend? Okay, most of you would select PEEP. All right. Why wouldn't we give a bronchodilator treatment? That's what got us in this place, got us there in the first place. Remember how I said the kid was having BPD spells shortly after giving a bronchodilator? Well, what does a bronchodilator do? It relaxes the smooth muscle around the trachea, and it makes that airway floppier, right? So in the next slide, this is the same patient, and the next day pulmonary medicine came in, and we placed a bronchoscope down into the airway. And I want you to observe the trachea. This is the trachea right here. This is the posterior membrane of the trachea. This is the cartilage going around. You're looking straight down into it. This is the carina. That's the right main stem. That's the left main stem. This is going to be the PEEP setting that we're using. Oops. Okay. Anytime you see bright light, that means the airway's collapsing all the way down. Look into the distal airways too. The distal airways are winking at you. They're collapsing too. So this kid has tracheal and bronchomalacia. Okay? See the airway just collapsing downward. Now we've given 10 a PEEP, and the airway is staying open longer. There's less collapse, and we can appreciate the distal collapse in the lung. Is that enough for this kid? Nope, because he's actively exhaling. The only thing that's going to overcome that sometimes is 15 a PEEP. So in these babies, this one in particular, this baby required 15 a PEEP just to keep that airway pneumatically splinted so that it wouldn't collapse every time. How many of you would feel comfortable with this PEEP level? Not many, right? Because I think for the most part, we're scared of PEEP. We're PEEPophobic. But when you have excellent airway graphics to guide you, you don't need a bronchoscope. Bronchoscope is unnecessary, especially because it creates a choke point and may actually kind of underestimate the amount of PEEP that's actually needed. But just using your airway graphics like this right here, you know that on exhalation, that airway is closing down, it's opening, it's closing, it's opening, it's closing on exhalation. So all you really need is airway graphics to guide you as you adjust your PEEP. Okay? That's a very valuable lesson, I think.
So where is the other place that you would see this type of flow versus volume abnormal loop in a patient that we commonly see in the ICU, where you have an abrupt decrease in flow at the onset of exhalation?